Please wait for 10 seconds before starting. Thank you. We can start, sir. Thank you so much.
Thank you, Tarun. Greetings from the Indian Society of Transfusion Medicine. And this was a forum set up exclusively for practicing medical doctors in the field of transfusion medicine in 2011. And the first president of this was our previous HOD, Professor Neelam Marwa. And the first secretary was Professor R.K. Chaudhary. Sir is online from Sanjay Gandhi PGI, Lucknow. We had few special interest groups created, and one of them was the blood donor management, of which Professor Ashok Yadav is the convener, and I have been appointed as the chairperson. Sir is busy today in some inspection, so he has asked me to take this program forward, and I would request Professor R.R. Sharma to kindly put in a few words. He is the present secretary of the Indian Society of Transfusion Medicine.
Good afternoon. Thank you, Sujit, and good afternoon, everyone. First of all, I would like to congratulate you and your team for this initiative. I think this is a wonderful initiative. And on behalf of Indian Society of Transfusion Medicine, I would like to congratulate you again and welcome everyone, and thank all our speakers, I think national as well as international, Professor Karja, who has spared her valuable time and consented to be with us today this afternoon. So as we all are aware that safe blood supply is the cornerstone of any healthcare delivery system. So for this safe blood supply, we need to have safe donors. And it has again been reiterated in the recent action framework of World Health Organization, which is recently released from 2026 to 2030, where again they have found that still different parts of the world are still struggling for safe and adequate blood supply. And one of the major challenges is inefficient donor recruitment and retention strategies. Because we know that majority in lower middle income countries and middle income countries, the donors are primarily either replacement donors or at places sometimes paid donors. So voluntary blood donor percentage is less. And if at all it is so, the first time donors are the majority donors and regular repeat donors are very less. So the challenge still remains, as we know, this program is very well structured, because in developed countries, the donor base is shrinking, the donor is aging, whereas in developing countries, we have a lot of population, but still effective recruitment and retention strategies are not in place. So I think with this, I would like to invite our first speaker for the day, Professor Karja, who is an eminent epidemiologist and health scientist at the VU University of Amsterdam. And she is a scientific member of Biomedical Excellence Research, Biomedical Excellence for Safer Transfusion, Collaborative Donor Studies Team, Chair of European Blood Alliance Donor Studies Working Group, and she is the editor of Vox Sanguinis Donors Donation Section, and an incoming regional director for Europe at the International Society of Blood Transfusion 2026-2030. Dr. Karja's research primarily focuses on health effects of donation, policies to monitor and maintain donor health, and more generally, donors' health status and eligibility to donate by using epidemiological and biostatistical research methods. So she shall be enlightening us today on towards personalized donor management, data-driven strategies to optimize donor health and blood supply. We welcome you, Dr. Karja, and thank you again for being with this, I think this is morning for you and afternoon for us. And I think sharing, and we would love, I mean, we will be happy to listen to you, and welcome again. Thank you very much. Over to you.
Thank you very much for the kind introduction and also for the invitation. I'm very happy and honored to speak to you today. I hope that you can now see my first slide.
Yes, ma'am.
Yes.
Great. So indeed, I'm going to talk to you about our research working towards personalized donor management based on data-driven strategies. And this is mainly based on the Donor Protect project that I am going to work on from September on very soon. I often get the question, why are you studying donor health? Because these are healthy individuals. So why would you, well, even bother worrying about the health of donors? But the underlying principle to donor health research is, of course, that we need these healthy donors in order to get the blood products that we need. And we have to make sure that they are not been done any harm in the process of donating their blood or plasma. So that's an important underlying principle because they are so healthy, and of course they are volunteering, and also because they really rely on the care and the guidance of the blood service and its medical practitioners, that we also know what the health effects of donations are. So if we don't study that, we don't have anything to inform them about, and we might be causing them harm without even knowing that. And of course we have to prevent that. Apart from that, another principle that I personally think is important is that we make optimal use of the material that the donors are donating by also using the remainders of their donations for research when that's, of course, of additional use. So not only use it to help the patients, but also to further the medical science in a more general sense. And of course, transfusion science. Just a little bit background on where I'm from. I'm from the Netherlands, where we have one national blood supply organization, the Sanquin Blood Supply Foundation, with approximately 2,000 employees. And within that, we have a research department with about 200 employees, where we do all kinds of research. So I'm mainly doing the epidemiological research on donors, but there's also work done on more sociological and psychological studies by my colleague Eva Maria Merz, and many more laboratory-based research, so immunological, proteomics, things like that. Our blood service consists of about 50 fixed blood collection centers, and there's also 5 mobile units that travel through the country and then, of course, have mobile sessions at various places. And our donor population was in 24, consisting of approximately 440,000 donors. It has been increasing a bit, who altogether make about 750,000 donations per year, of which now more than half is plasma donations. It used to be the other way around before. And that's actually shown here. And this is also the challenge that I wanted to talk to you about, because we are currently looking at a declining demands for decades already for whole blood. So we're collecting less whole blood also over the years. And of course, that's positive news because less blood is needed. And we become more and more efficient and also careful in when to use blood transfusion and when not to. But at the same time, we see quite steeply increases in plasma collections because of the rising demands. And even though we are now collecting more plasma in the Netherlands than in terms of numbers of donations than whole blood, we still, in the whole of Europe, import about 37% of our plasma from other countries, mostly from the USA, where donors are paid to donate their plasma, and they can even donate twice a week, which we think is probably not very safe to do. And the global demand keeps on increasing. So this is really a challenge that we have. We have to make sure that we have enough donors to make all those donations. But we're also, of course, considering collecting more frequent donations from these donors in order to keep up with the demand. And there, of course, comes the important question, what are the health effects of these frequent donations? I'm first going to start to discuss the effects of whole blood donations, because that is something that we've been researching quite intensively over the past years. So we've done a lot of studies on donor iron loss, which of course is mostly happening in whole blood donations, because of course of the large amount of iron that is in red cells, in the hemoglobin levels of donors. And we know that with one donation, approximately 200 to 250 milligrams of iron is lost, which is quite a lot to make up for. And actually, in comparison to the total iron stores in women, it's about half of their iron store that they lose with one donation, which of course needs to be compensated. And for men, it's about almost 1/3 of their total iron store that they lose. And what you then see, so it takes about 2 months to recover your hemoglobin levels after one whole blood donation, at least in healthy young men. And we've seen in a study that we've done at Sanquin that actually the reportings of side effects of this lowering of your hemoglobin levels takes about only a few days until you really clearly feel better. So it's mostly fatigue that donors report in the days after their donation, but after a day or 3, they already start to report feeling less fatigued and more back to their normal levels of fatigue. But of course, while they are recovering from their donation, also by replenishing their hemoglobin levels and becoming less fatigued, they are actually using the iron from their iron stores to, of course, make these new red blood cells and hemoglobin. And while these iron stores are being depleted, it takes about 6 months or even longer to replenish those iron levels, so to get back to their pre-donation ferritin levels. And we've seen this in the same study where we've studied healthy young men, so aged between 30 and 50 years. And there it takes approximately 6 months, but we expect that women, especially premenopausal women, need even more time. So there's various factors that influence this recovery of iron levels after whole blood donation. One aspect is, of course, their genetic makeup, what people eat. Do they eat lots of iron, yes or no? Also makes a big difference, of course. And then there's factors like sex, menstruation, and menopause that have an additional effect because of the blood loss associated with that. So in terms of recovery, ferritin is an important factor to take into account. And one of the studies that we've been doing in the Netherlands over the past few years was the FINEM study. This was a study where we investigated the effects of a new policy that was implemented at Sanquin, where donors' ferritin levels were measured every 5th donation and also in all new donors. And if their ferritin levels were too low, they were deferred for 6 or 12 months, depending on their level, to give them additional time to recover their iron stores and to prepare them for their subsequent donation. And this policy was implemented by means of a stepwise randomized, cluster randomized controlled trial, which means that we randomly allocated all the donation centers in the Netherlands to different time points to implement this new policy. And then we could, at these various time points, compare the centers where the policy was implemented to the control centers where it had not been implemented yet, to assess the effects of the new policy, to see whether we could actually, by measuring ferritin and delaying their subsequent donation, could increase the iron levels in the donor population. And the results were pretty clear. So what we saw was that after implementation of this ferritin measurement policy, we saw that donors before the implementation of the policy, 1 in 4 were iron deficient, so quite a lot. And this declined from to 8% in women and to 5%, so 1 in 20 in men. So very, very sharp decrease and also very highly significant. And of course, this also has an effect then on your hemoglobin levels, because if your iron stores increase, you can also recover better from your donation and thus increase your hemoglobin levels. So we also saw less too low hemoglobin levels in the same population. So that declined from 7 to 4% in women and from 4 to less than 1% in men. And at the same time, we were able to keep the blood supply steady also because of the stepwise implementation. But it was really challenging to make sure that the blood supply was kept at a proper level, at a sufficient level. And many donors also came back to the blood service asking, what can I do myself to increase my iron levels? I want to replenish, I want to donate. What can I do? So because of that, we subsequently started another trial where we included donors that had these low ferritin levels and were therefore deferred for 6 or 12 months. And we randomized those donors to different iron supplementation policies. And the most intensive one was taking 60 milligram iron supplements every day for 56 days. And then we compared that to a placebo where they also got capsules, but these did not contain any iron. And what you can see here was that in the group that received 60 milligrams of iron to take on a daily basis, only 1%, so a very small number of donors still were iron deficient 56 days after their donation. But we looked into the details, and these were also donors that were non-compliant to the iron supplements. So they took approximately 1/3 of the supplements that they were supposed to take. And also these were the same ones that had low hemoglobin, so they would have been detected at the blood service upon their entry. So they would have been picked up anyway. And in comparison, in the control group, so in the placebo group, you can see that over half of these donors were still iron deficient 56 days after their donation without the iron supplementation, and 24%, so 1 in 4, still had low hemoglobin levels. So it really, really helps to recover much faster from the donation in iron deficient or low ferritin donors. Then to plasma. So as I said, we are now focusing more and more on plasma donations because we are increasingly collecting plasma and because the demand is rising so steeply. So we've also been looking in an observational study into ferritin levels in plasma donors to see what repeated plasma donations do to your iron stores. And we saw also here that there were declines with increasing numbers of plasma donations in the preceding 2 years, both in hemoglobin levels and in ferritin levels. And we expect that this is mostly due to the fact that even with plasma donation, we sample blood for testing, and there's also always some residue of red cells in the tubings of the plasma collection system. That of course also make them lose some blood and therefore also iron. So with really intensive plasma donations, also your iron levels can decline. But of course, we ideally want to look into randomized studies because with observational studies, we always have the problem with the healthy donor effect, that those who donate frequently are usually the ones that are more healthy, which could, of course, distort the associations that we're looking at. But there have been some small studies, unfortunately not too many, but one small study in Belgium that was published in 2024, which randomized donors to different intensities of plasma donation. And then there was another small study with 120 donors, both only with male donors, unfortunately. And they also randomized donors to different donation intensities. And what you can see here in both of these studies is that with intensive plasma donations, IgG levels, so immunoglobulin levels, they decline quite steeply. So they donated twice a week in this Belgian study and 3 times per 2 weeks in the Norwegian study. And you can really see quite clear declines in immunoglobulin levels over these repeated donations, which of course is quite worrisome, mainly because the immunoglobulins are the one factor that drives the demand for plasma. That's exactly what the patients need from these plasma donations. So the demand for immunoglobulins is rising, and at the same time, while donors donate repeatedly, their immunoglobulin levels decline, which of course then brings us to the results that more donations per donor are needed to be able to produce the same product. And unfortunately, the products are being paid for on a kilogram basis, and not based on their immunoglobulin content. So this is quite a disturbing, I would say, paradox here. That's not very positive or helpful. As I said, I'm going to mainly talk about my Donor Protect project. So last November, I received really great news that I got awarded with an ERC Consolidator grant. So ERC is the European Research Council, and they basically want to give an impulse to European researchers to help further their careers. And the Donor Protect project was funded with money to make some really nice impact in the field of donor health for the coming 5 years. And the main aim of this Donor Protect project is to develop personalized strategies that optimize donations from more resilient donors, so making them able to perhaps donate a bit more if they are able to, while at the same time protecting the more vulnerable donors and making sure to not over donate for those specific people that are more vulnerable to, for instance, iron depletion or immunoglobulin depletion. And while balancing those different factors, individual factors, we hope to be able to make the blood supply and also the plasma supply more sustainable in the long run. And the project consists of 3 sub-objectives. And the first one is, of course, to better understand what these health effects of both plasma and whole blood donation are. The second objective is then to design this algorithm with personalized strategies and to test that in practice. And the third objective is also to set up a European framework where we look into ethical aspects, also legal aspects and societal aspects to make sure that what we develop is also implementable in practice and something that could really be part of future guidelines. So this is how all these different objectives and work packages come together in the project. So the first part of the project is work package 2, where we run a plasma randomized controlled trial. And I will go into the details for that trial a bit later. The work package 3 focuses on whole blood donation effects and the effects of individual factors on that. And we use mainly existing data for that part. And then the input from both of these work packages help to develop the algorithms together with also existing literature that we already have. And these algorithms will then be tested in practice in another randomized controlled adaptive trial. I will also talk about the details of that a bit further later on. And then the final work package is on the ethics and guideline development, looking into these ethical and legal aspects to make sure that what we develop is also implementable. So that first study, the plasma study, is mainly aimed to investigate what effects donation frequency together with donor-specific factors have on donor health. So we'll be looking into short and long-term effects of different plasma donation frequencies. And we really want to determine who is more or less capable to donate frequently. And we are doing that on the basis of a design of a trial that is already being carried out at this moment in the UK, in the United Kingdom, where they already do the SHAPE trial that is currently ongoing. And we aim to really merge the 2 studies to be able to get sufficient power to look into these different individual factors. But within the Netherlands, we're already going to hopefully include a large group of donors, 10,000, both male and female donors. And we'll be randomizing them to different donation intensities for 1 year. So they will donate either every week, every 2 weeks, every 4 or every 8 weeks. And of course, at baseline, we make sure that we really get to characterize all these donors. So we will measure various biomarkers, also their genetics, and questionnaires to get an idea of their medical history, their lifestyle behaviors, basically everything that we can think of that might be important for their effects of these plasma donations. And then after 6 and after 12 months, we will assess the outcomes, which mainly look into changes in biomarkers, so both the ferritin and hemoglobin and red cell associated biomarkers, but also immunoglobulin levels, of course, and total protein levels. And in subgroups, we'll also look into to immune cells, so B and T cell subsets, and proteomics to really get an impression of what changes we can see in the proteome, in the proteins that these donors have in their blood. And of course, we will monitoring adverse events to see if perhaps they some of these groups, if they donate too often, maybe become more regularly sick or not. And we hope to find the answers to the health effects and also the different individual factors and how they impact these. Then as I already said, the work package 3 will focus on the effects of whole blood based on existing data. So we will look mainly on these iron factors, iron stores, but also red blood cell parameters. And what my PhD student Lucas Janssen is mostly going to look at is how genetics may impact the recovery in iron parameters over several donations. Also how diets, dietary intake of iron mainly, heme iron, impact these ferritin and hemoglobin levels, and of course also the impact of sex, menstruation, and menopause. And I will also go into a bit more detail of that later. And he's currently looking into the Helios cohort, which is in Amsterdam, a multi-ethnic cohort. So we're looking into why certain groups, mostly from sub-Saharan Africa, have generally lower hemoglobin levels than, for instance, the Dutch population. And we're going to look, or we are currently looking into whether this relates to their genetics or maybe their dietary iron intake or other factors. Because we don't know whether it's something that's more physiological or maybe it's something that is a result of their different iron intake and should therefore be taken into account. So can we maybe use a different cutoff for hemoglobin for this population, or would that not be a very healthy way to go? A second study that we're making use of is this Forte trial, so the iron supplementation trial that I talked about before. We also have the genetics of this entire cohort, so we're also going to look into, are there certain genetic factors that impact how these donors recover their iron levels, and with and without the iron supplementation. And we're also going to look into data from the interval trial in the UK, which is a really large randomized controlled trial with different whole blood donation intervals. And they also have all the questionnaire data and the genetics on this cohort. And then last but not least, the FinGen. So the Finnish population is genotyped to a very, very large extent. So we're also going to look into their data to see if we can reproduce the findings that we will hopefully find in the other data sets. Then the algorithms that we will develop in work package 4. So this is going to be really a collaboration between the PhD students and a postdoc that will start after about 18 months into the project. And what we're going to aim for is that we're going to make algorithms that help us to decide per individual donor what type of donation he or she should ideally make and at what frequency. And factors that we then want to take into account are these genetics that I just talked about, biomarker levels and their temporal patterns, dietary intake again, and then the factors associated with sex and menopause and menstruation. And for the genetics, there's currently the genomics consortium that has developed a transfusion-specific genetic array that includes blood types, HLA types as well, and there's also several iron markers on that same array. So that could be of use to screen donors for their blood types, and then at the same time see if they have some kind of genetic makeup that also makes them, for instance, absorb more iron from their diet or make them more efficient in their erythropoiesis or hepcidin regulation and iron storage. So all of these different factors could be of impact, and we hope to find answers to that and then take that into account. And then another factor that I just mentioned were the biomarkers. So we've been doing some analysis with like the simple regression analysis, but also machine learning to try to predict future hemoglobin levels based on previous hemoglobin levels and also other individual factors. And of course, we're going to build on this to improve these predictions. And what we mainly are looking at right now is to use these predictions to find the ideal number of donations that somebody should make in order to prevent them from getting too low ferritin levels or iron stores. And this is an example of a table that was produced by Dr. Mart Potas together with a donor physician in Sanquin, Jared Paalvast. And they developed this table based on computational modeling. And if I then, for instance, look at myself, I have approximately a body weight between 50 and 60 kilograms, and my ferritin will also be around 50 or 60 nanograms per milliliter. So for me, it's probably best to donate about once a year and not more often, because then my iron stores would become too depleted. While at the same time, a woman with a body weight of 70 to 80 kilos and higher ferritin levels might be able to donate 3 times a year. So this helps to decide what a more feasible and also capable frequency would be for a specific person. And I also mentioned a couple of times already that diet is an important factor, and we've studied this in our donor insight cohort some years ago. We used food frequency questionnaires there to assess the total dietary intake from a large group of donors. And we mainly calculated how much heme iron they took up with their diet, and also their non-heme iron. And as you may know, heme iron is only available in animal-based foods, and non-heme iron is in animal-based and also plant foods. But it's the heme iron that is easy to take up from your food, and that really helps to replenish those iron stores. And we also saw in this study, I don't have the details on this slide here, but you can look it up in the original paper. We saw a very significant association of heme iron intake with both ferritin levels and hemoglobin levels. And there was even a mediating effect of these iron stores on the hemoglobin levels. And we saw basically no effect or even a slightly negative association between non-heme iron intake and ferritin and hemoglobin levels. So it's really, it probably makes a difference if someone is following a dietary diet or not, in terms of how well they will be able to recover their iron stores after these donations. And we're currently looking into whether indeed a simple question about a vegetarian or vegan diet would be sufficient to already detect the low heme iron intake. And we're studying that also in our further study cohort. Then sex and menopause. I think you all know that in general, women have lower hemoglobin and also lower ferritin levels than men. But what we also see in these data here is that if we divide our female donors into those aged above 45 years or below 45 years, so a rather general estimation of whether they would be pre or postmenopausal, we see very significant differences in how many of these donors have low hemoglobin levels or are iron deficient. And clearly, this is much more prevalent in the donors that are still menstruating. And a couple of years ago, we also used a data set where we had actually asked female donors to complete this pictorial blood assessment chart, which is quite a cumbersome device, but it is quite a valid one to assess how much blood is lost during one menstrual product. So these donors were asked to count all of their used products during one period and also how saturated these products were. And then you can use that with formulas to estimate how much blood they use with that menstrual period. And we saw that these that the amount of blood lost during their menstrual periods is very significant, also associated with their ferritin and hemoglobin levels. But of course, we don't want to ask all the donors to count all these products every time, or at least not even once. So we had a PhD student who recently started, who did an internship before, where she developed this menstrual blood loss symptom checker. And this is a much simpler way to assess whether or not someone is a heavy menstrual bleeder. So there's just a few questions, and we validated this against the pictorial blood assessment chart 1 year ago. And we could see that the combination of these 3 items, or probably even those 2, they are in Dutch, I'll read them out. But the combination of these items are already sufficient to detect a high likeliness of having heavy menstrual bleeding. And this first one is having to change your menstrual product every 2 hours or more often. The second one is leaking through your menstrual products. And then the third one is having a menstruation longer than 7 days. So this is the symptom checker. And we're currently trying to find ways on how to implement this in practice. And we're going to do a pilot soon to actually assess this at our blood bank in the Netherlands. Then the subsequent work package is about the algorithm development. And as you can see, we really want to work towards taking all these different factors into account to work towards personal donation advice. And this is just, for instance, a female donor here. She might have low hemoglobin levels and low ferritin levels, and then be advised to only donate once a year if she wants to donate whole blood, or maybe 6 plasma donations. And in comparison, you could have a male donor with high ferritin levels, high hemoglobin levels, who could then be advised to donate 5 times a year, or quite often the plasma donations. But if we then enrich these data with more specific information, for instance, on their diet, so it might be that this female donor is also a vegetarian and she has heavy menstrual bleeding. If that's the case, then 1 donation per year would probably already be too much. So we could advise to donate even less, or maybe take some additional measures like contraceptives or iron tablets to make sure that she's capable or able to donate a bit more often than less than once a year. And also, plasma donation is probably not the wisest thing to do too often. And on the other side, this male donor could be someone who really loves barbecuing and eats lots of meat, therefore. And maybe he also has a genetic predisposition to absorb lots of iron. And in that case, he might be able to donate more often than 5 times a year, and also many, many plasma donations. So this is a bit of an example of how these algorithms, what they could look like and how they could work in the future. And once we have developed these algorithms, this is what we're going to do next. So we're going to do an adaptive donation algorithm personalization trial, where we will randomize 21,000 donors, so 3 groups of 7,000 donors, to donate according to the current strategy that we now have in place, so without any algorithm use, but just a distinction between men and women. So in the Netherlands, women can donate 3 times a year, men 5 times a year, or they can donate plasma up to 26 times a year, so every 2 weeks. The other 7,000 donors will be randomized to a basic algorithm that will be based on the information that we already have in our system. And then the third group will be randomized to a refined algorithm that also takes factors like genetics, diet, and heavy menstrual bleeding, for instance, into account. And then after 10 months, we'll do an interim analysis to see whether or not we are capable of keeping the biomarkers of interest, and these are probably going to be ferritin, hemoglobin, and IgG, and total protein, to see whether we can keep those at a steady level in these donors with these different algorithms. And if not, we want to adjust the algorithms, so find the cause of declines or maybe of more incident adverse events that donors may report, because one of the main goals, of course, is to keep these donors healthy. And if we're not able to do that, then we need to further refine the algorithms. So then after that, we will proceed the trial with still the same current strategy, and then potentially improve strategies. We might even decide to drop one of the strategies if it's not working at all. And then after 18 months, we'll also assess the outcome in terms of donation numbers. So the plan really is to see whether we can keep donors healthy while at the same time collect more of the donations that we need. And then the final work package of this Donor Protect project is going to look into the ethics and legislation and societal impact. So like I said, we're going to do analysis also in different countries to see which legal aspects should be taken into account. Of course, the donors, they are voluntary, so we want to look into their solidarity aspects and to what extent can we ask them to donate at certain frequencies in order to make sure that we meet the demands. So what can we really ask, and how should we balance our demands and supply. And we're also going to look into privacy aspects. So what data can we use in order to work with these algorithms? What can we ask from the donors? So we're going to do interviews with donors, cross-cultural analysis, and also literature reviews to be able to make sure that in the end we can make sure that we work towards healthy donors that are also happy to keep on donating in a way that is sustainable and responsible. So to summarize the Donor Protect project, it will give us some new insights on donor-specific health effects, mainly on the plasma side, but also on the whole blood donation part. That is going to be used to develop these personalized algorithms, and we're going to all take those into the perspective of ethical, legal, and social guidelines to make sure that it's going to be a new way of working in Europe and hopefully also outside of Europe, that we can actually use to make the blood supply more sustainable, more responsible, just future-proof, basically. And to conclude, overall, as you've seen also in the trials that I've reported on, we've shown that ferritin-guided intervals can reduce iron deficiency and also low hemoglobin. But they also, unfortunately, reduce donor availability, as was shown in our FINDEM trial. And to make up for that, we've shown in our FORTA trial that iron supplementation for donors with low ferritin levels may offer a safe and effective alternative, and is actually seen to work well, especially in women, which probably is because then it also compensates for their menstrual blood loss in a way by giving them this additional iron. We do urgently need more information on the effects of high-frequency plasma donations, but hopefully when all the planned work is going smoothly, we will be able to report on that in the coming years. And well, I really hope that with personalized donor health protection strategies, we may improve both donor health and the blood and plasma supply. And with that, I want to thank you again for your attention and for the possibility to talk about my research here. And please feel free to ask any questions.
Yeah, thank you, Dr. Katza, for an excellent talk. I think you have covered various aspects of donor health. I think I must congratulate you and your team for various systemic studies which you have done and which are undergoing, and wish you good luck for the future studies. So before we move on to further, I would like to welcome our co-chair, Dr. Akanksha Bist also, who is here with us from National Institute of Biologicals. May we have her introductory slide, please? She is a young, dynamic, I think, personality who has many awards, and she has been instrumental in, I think, setting up the hemovigilance program in our country. And may we have her, and recipient of many national and international awards. May we have some comments from Dr. Akanksha Bist, please. Over to you, Akanksha.
Thank you.
Then we will have comments. Yeah, sure. Please.
So thank you so much for the kind introduction. And I welcome, because there was an internet connectivity, I couldn't welcome Dr. Katza, but definitely your presentation, it has given an insightful and thought-provoking presentation. And your talk has clearly highlighted the importance of personalized donor management and transformation role that the driven data approaches can play in improving the donor health. And being involved in the national level data collection through the country's hemovigilance program, I think the use of the wealth of the data which is being generated can be utilized to develop these effective strategies for optimizing the donor health and the blood supply. And your presentation has definitely given us an insight that we also need to capture much more data in order to understand what is a donor need and how the donor safety can be done. So with these words, I really thank Dr. Katza. And a quick question before we take from other people, if they have mentioned in their comment box. Dr. Katza, do we really need to have a minimum national data set required to develop a meaningful donor risk stratification of the personalized donor management programs?
I mean, you mean, do you need to have a national data set then, or
do we need to have a minimum there's some set national database, a minimum of this number data should be there, so that we need to develop that meaningful donor risk personalized donor management programs. So.
Yes, it probably depends on what turns out to be important factors to measure, and then per question you need to do separate sample size analysis. I would say to see how many of this information you need in order to be sure to be able to draw the right conclusions. So the answer is yes, but how many would differ per factor? So that's hard to say. Yeah.
Sure.
Yeah.
Thank you so much. Thank you, sir.
Yeah,
Thank
you. Thank you, Akanksha, and thank you, Katsa. Yeah, I just have one or two questions, then we'll open this for discussion, maybe for a few more questions. I was just wondering, I think you mentioned about plasma donors and you are estimating some biomarkers. So I was just wondering, besides plasma proteins like albumin, immunoglobulins, what other biomarkers do you intend to estimate in these donors? And in addition, what is your policy for remuneration? Are these purely volunteer donors or are they paid for their plasma donations? And how does your legal framework allow it? How do you go about this in your country?
Yeah, thank you. Yeah, so the donors in the Netherlands, also plasma donors, are not remunerated, so they don't get any payment for their donations. It's all on a voluntary basis, and that's also written in the Dutch law for blood transfusion and blood collection. So they don't get any compensation in that way. What was your other the biomarkers that we're measuring in the plasma trial? We're going to do a whole blood count. So we're going to look into all the red cell parameters. Ferritin is going to be measured, and like I said, immunoglobulin and the proteomics. So that's a very large spectrum of also different types of immunoglobulins and other proteins. And what else are we? Yeah, the total protein levels also. And I think that's it for now, but we are going to also store samples to be able to do additional measurements also later. Oh, and the genetics I forgot, but that's something we only measure at baseline. Yeah.
Thank you. So we have Professor R.K. Chaudhary from SGPJ. We welcome you, sir, for being with us here this afternoon. And maybe hear your comments from on the talk of Professor Karza, please.
Yeah. Thank you. Thank you, Dr. Karza, for very beautiful presentation. I have just a couple of questions, and they are sort of generalized questions. You collect so much of personal information of all these donors. So how do you balance this personalized information of the donor with data privacy and the regulatory requirement? This is one. And second question is, how do you measure the long-term success of a blood donor management program beyond simply the number of units collected? So these are my two questions.
Yeah, thank you for these interesting questions. Yeah, so in terms of the privacy legislation, that is indeed an important one. We're going to collect quite some detailed information on these donors, and we do aim for minimal data really to be used in the algorithm. So like I said, we're not going to ask them about their entire diet, but only a yes/no question in terms of do you eat vegetarian or vegan, for instance, yes or no. So that's one aspect of it, that we minimize the amount of data that we actually are going to ask. And of course, if it turns out that some of this information is not helpful to improve the algorithms, then we won't use them, and we also won't ask for that. But it's one of the things that we also want to study in this ethical work package, to see how far can and should we go in order to be able to protect the privacy of our donors, while at the same time improving their health and making sure that we protect them in an appropriate way. And I think there's some fine balance somewhere that we have to seek. And then your second question was about the long-term effects of implementing these algorithms, right? And how we're going to assess that.
How do you measure the long-term success of this blood donor management program beyond the number of units collected?
Yes. Yes, that's so I just presented, of course, what we're going to do in a trial. And I think the trial will be the basis of a decision on whether or not to really implement it in practice. And then I think what we've done with the ferritin guided donation intervals policy, so do that in a stepwise randomized controlled way, that could be a way to also implement these new algorithms. So to randomize centers and implement it first in some, and then roll it out gradually over the other centers, that also makes it possible to compare the effects on various aspects over a longer term. So I think that should be the way forward if we're going to actually implement it in practice on a long-term basis. Yeah.
Thank you, Dr. Karza. Now, maybe have one or two quick questions if there are any from the audience. Yes, Satyam, you would like to say?
Yes, sir. So thank you, Dr. Kaja. I think it was a really great presentation, really shows the amount of work that your team and you are leading in Amsterdam and probably globally. So there were just two, three things that I wanted to ask. One of them were from your, famous Forte study, and it's probably one of the landmark studies. And you used a cutoff of 30, which I feel a lot of groups define iron deficiency at less than 30 ferritin levels. So do you feel, or did you consider using another cutoff? Because if somebody is below 30, it's kind of towards iron deficiency itself. And a lot of our donors may not have a ferritin at that level. Second is from the same study is you did a lot of work with hepcidin, and do you think hepcidin will have some role in managing the iron levels and screening these donors? And third, I think is something, iron management for our regular donors has been a puzzle for multiple decades. So what do you feel is still one of the most important unanswered question that groups in India or maybe globally can work on, for more better optimization or finding some ways of better optimizing iron in our donors? Thank you. I know there's a lot, but I hope you should be able to.
Yeah, many questions, but thank you. Very interesting questions and very important ones. And I think actually I can answer maybe your first and your third question at the same time, because I think there's a lot to answer in terms of the right ferritin cutoffs, but also standardization of the measurement, because that I think is the main issue with ferritin measurements now, that there's no standardization, and there are some standards like how do you say that in English? Well, there is a WHO standard for ferritin, but apparently that also behaves differently with different types of assays. So there's a big problem in terms of the ferritin measurement, and that translates to the same sample showing with twice as high ferritin levels with different laboratory assays. So that makes it really hard to find what the right cutoff is. And we're going to try to come up with a temporary solution, but this is also something that in clinical chemistry needs to be solved in a way. And I know that it's going to take years to do so, but that's probably then the most important unanswered question at the same time. And then the second question that you asked was about hepcidin, yes. Yes, so we did measure hepcidin in one of our first studies on iron, but actually the levels in donors are so low because, of course, when you're iron deficient, your hepcidin goes down to be able to attract enough iron to restore your iron stores. So it's quite hard to use hepcidin levels for donor monitoring, because generally they are at an undetectable range if the iron levels are too low. So I think ferritin is probably still a better way to monitor, but you have to then compare it to ferritin levels within the same donor, measured with the same array, and or assay. Yeah.
So thank you very much, Dr. Karza. Hope that answers your question, Satyam.
Yes, sir. Yes, sir. And I think, sir, there is a question in the Q&A. If you
I think maybe this may not be applicable to Karza. If they say that if ferritin level whole blood donors are adequate after 4 donations per year, would you recommend subsequent donation more than 4 or 5 whole blood donations per year? I think the answer would be no, because it has to be, because there is law. Transfusion services in our country are bound by Drugs and Cosmetic Acts, and then the donations, maximum donations allowed are 4 for men and 3 for women. So I think we should not do that. Maybe we are not sure. What about yours, Karza? How do you go about it in Netherlands? Do you have a fixed number of donations for men, women, or?
Yes, we have as well, but we allow 5 donations for male donors in the Netherlands per year, and 3 for women.
Yeah. So I mean, there is a fixed number. So is in our country. So thank you very much, and thanks for that wonderful talk. And thank you, everyone. I think everyone joined us for a fruitful discussion, and hopefully your talk must have motivated young minds. And yes, of course, it has motivated us also to do some good donor studies in our setup also. So looking forward for more collaborations in future. Thank you again for joining us.
Thank you very much for the invitation again. Thank
Before
you.
we go ahead, maybe request all the speakers, chairpersons, and the SIG members to put their video on for a small click with
Yeah.
our inaugural
With our-
speaker, Dr. Kaja Vanden Herk.
Yeah.
Anybody? Dr. Rasika? If this is all, yeah, thank you. Tarun,
you.
would you take a few pictures? Dr. Ashok Yadav sir is also here. We welcome him. He is the convener of this SIG.
Yes, sir. Yes, sir.
So over to you, Suchet. I think we can move to the next session.
Thank you. Thank you, Dr. Kaja. So we proceed further. We request you to stay online if you can for some more time. Otherwise, as per your commitments. Thank you so much. You've been
Thank you.
of great help in enlightening our fraternity and students who are online with respect to donors. So all of us actually run, maybe our buzzwords are patient blood management. So there is a evolving concept. We need to talk about donors blood management also. And in that, your work is the preliminary steps towards framing a policy toward donors blood management. Thank you so much. And now there is a debate that should India increase the upper age limit for blood donation. We have two speakers and we have two chairpersons. The chairpersons are Dr. Rajendra Chaudhary and Dr. Ravneet Kaur, madam, and I will hand over the session to them to take it further.
Yeah. Thank you, Suchet. Can I have the presentations or the slides of the speakers?
Yes, sir. Arun?
So this is a debate on the topic which Dr. Suchet has mentioned about whether India should increase the upper age limit for whole blood donation. And one of the speaker is speaking for the motion, and the second speaker is speaking against the motion. So I request Dr. Ravneet, the co-chair, to please introduce Dr. Abhishek Gowda, who is the first speaker.
Good afternoon, everyone. So the first speaker for the motion is Dr. Abhishek B. He's head transfusion medicine, JIPMER, Pondicherry. He has 14 years of experience and he has publications. He has written books. He's member of Journal of Transfusion and Immunohematology, and his area of interest is immunohematology, patient blood management. And he'll be speaking for the motion. So over to you, Dr. Abhishek. Dr. Abhishek.
Tarun, please allow.
Am I audible?
Yes, Abhishek,
Yes.
you are audible.
Yes, okay.
Yes.
You can share your screen and put up your PowerPoint.
Dr. Abhishek, are you sharing? Yeah.
1 minute, ma'am. Is my screen visible now?
Yes.
Yeah, I would just request you to put it on a slideshow.
Now?
Yes.
Slideshow.
Yes.
Yes.
Okay.
So-
Okay.
Okay.
Yeah. Thank you, Chaudhary sir and madam, for that introducing, and of course ISTM for this webinar. So of course this is a debate, and I would be putting my points across as to why I feel India should increase the upper limit for blood donation. So, are you Anybody knows this structure or the image that is shown there? Okay, so this is supposed to be the oldest bridge ever documented, built almost 5,000 years ago, that is 3000 BC, and it is in Greece, and it is called Adicon Bridge. And the best part is, even today the bridge is live, in the sense people use this bridge. You can see the car going over there. So why I put this picture is, raising the upper age limit for blood donation is like allowing well-maintained bridges to stay open longer. If the structure is strong, regularly inspected and safe, there is no reasons to close it just because it has reached a certain number of years. So with that analogy, let us see. So this is just a slide to see what is the upper age limit for blood donation in various countries. In India, we have for the first time donors at 60 and for repeat donors at 65. Just let us see through various other countries like USA, Germany and all. So USA almost has no, of course USA, each state has a different thing, but most of the states do not have an upper age limit at all for a repeat donor. Whereas for the first time donors, it is again variable somewhere between 60 to 75. Germany, you can see there 68 for both first time and repeat. Singapore has increased to 65 for the first time donors and repeat donors up to 75. Canada does not have an upper age limit at all for both first time donors and the repeat donors. Likewise, UK, Australia, Netherlands, New Zealand, and even the Brazil has allowed upper age limit of 69 years in both the cases. One argument may be there that we don't have anything from the developing or the third world nations. The problem is maybe the documentation or this one. I could not get the data from other countries, but this is what I could lay my hands on. We can see that most of the countries have a very liberal strategy with regard to the upper age limit for blood donation. We will see as to why this may be and what could be the implications. Let us see for India with regard to India. So this is the distribution of donors in India age-wise. If we see there, I agree that most of the percentage of donors with regard to age constantly increases, majority being in the age group of 18 to 25, followed by 26 to 35 and so on. But we can see that a sizable number of population, that is around 10%, and about 15% can be seen in 50 to 60 age group, and more than 60, 10%. Mind you that more than 60, especially it is regulated by this one, and that may be the reason why we see such number of percentage. But it's important to know that about 10 plus 15, around 25% of the donors fall in this age group from 50 to 65. So that is a sizable number. And it is expected that by 2050, throughout the world, 25% of the population will be in this age group. Okay, so that is like 1/4 of our population will be in the age group of above 50 and 60. So that's a very sizable number. And with regard to both the requirements of blood as well as with regard to availability of donors, this will be very important. So this is few articles I got from publications from JAMA and also from Vox Sanguinis. They have in detail discussed about the clinical and policy consideration for blood donation by the elderly. with regard to the safety, see, whenever we talk about any blood donation, we have two things in mind: whether this blood that we are going to take from them will not affect the donor himself, and the second one is whether this blood will affect the recipient. Now, coming to the donor's safety. So this paper, which spoke about the safety of blood donation by elderly blood donors, it showed that the relative risk for adverse reaction was distinctively lower in elder donors, that is with a relative risk of 0.3 to 0.7. That means much lesser than the other group of population which had the adverse donor reaction. And they also say that their data confirm that elderly regular blood donors may safely continue blood donation at least till the age of 71, and this risk is not going to decrease up to 71. That is what they concluded in their paper. Now, let us see if the second part where we are looking at, whenever we talk about effect of this blood on the recipient itself. So first is probably about the transfusion transmitted infections. This is just a breakup of TTI positivity among donors in the age groups. So if you see that the peak, this is a prevalence, so we have to understand that it goes on adding up as age passes. But you can see that the peak percentage overall positivity is around 46 to 50 years. But after that, you can see 51 to 55, there is no data beyond that. But obviously it will be probably lesser than that. Barring HCV, which is possibly, we all know that most of the HCV positivities that we see in our country are people who have got it a few decades back. So barring that, if you see either the HIV, you don't see 0% in 51 to 55 years. And probably syphilis is because of the biological false positives, which we generally see with the VDRL and RPR methods. So otherwise, with regard to overall positivity, we can see that both the HBV and with regard to HIV, the ones which are more concerned are very low in this age group of population. So the scare that whether these people have a higher chance of TTI transmissibility is probably not substantiated. So next is whether to see non-infectious complications or outcome from the transfusion. So this is from the large study, that is the REDS-3 study, where they studied age and also with other things. It showed that 93,000, almost a lakh patients who were transfused with RB 4 lakh plus units, they showed no association between donor age and recipient in-hospital mortality. So transfusion of RBCs from donors less than 20 years old was associated with shorter hospitalization. Okay. So though the hospitalization was probably shorter in them due to various causes, probably because oxygen carrying capacity and all, but with regard to mortality, they did not find any difference. So with those two things, both the infectious and the non-infectious care, or this one that we have concerns with regard to the elderly donor, actually is not substantiated by the evidence. This is also another study where they studied association of donor age with survival of patients receiving transfusion, and they also said that age and of course sex are unlikely to influence the survival of patients receiving transfusions. Now, this is a study or data from WHO, which says annual requirement of blood in India is about 14.6 million unit, and there is a chronic shortage of about 1 million units. And also 12,000 patients die daily just due to lack of blood in India, and that number is definitely concerning, and we need to do uh, something about that. And one of the ways I think is this one. This is another from the recently from the Hong Kong, which Hong Kong and Singapore, where they raised the upper age limit for the first time donors from 60 to 65, and new donors can well, the repeat donors can donate up to age of 75. And this is another wherein this is from the European Italian National Transplant Center, and they consider alternative donation types for older donors to reduce iron loss, which we are generally talking about. One of the concern is that these people become anemic, or there is a non-anemic iron deficiency. And there they have clearly told that in those, even in those kind of donors, you can consider alternate types of donations like plasma and platelets by apheresis, and thereby allow them to continue to donate blood and not stop them from prevent or defer them from donation just because of their age. Let us look at the population pyramid of India as per 2023. So we can see that most of the population, of course, India is comparatively younger as of today, but with the prolonged longevity of life and other things, if you see the population around 60 and 60 plus is likely to increase in the coming days, and turning them into blood donors will definitely go a long way in ensuring that the required unit of blood is met by the country. So now we are talking of scientific evidence and other things to see whether increasing the age for donation actually easy to find or not. Then we also want to see whether what does the donor feel. So this is a study where they studied perspectives from the donors himself, whether they are okay with increasing the upper age limit for donation. And they found that 92% agreed with the increase of the upper age limit, and these were the donors who have been either in the age that they are likely to be deferred from donation, or they were allowed to donate because of the change. And approximately 63% of the participating donors felt obliged to continue donating, especially women with higher education. And donors also indicated they felt healthy enough to keep donating, 95% of them, and 72% thought it is good for their health to keep donating. So it's not only about the policy making, the donors themselves also feel that the increasing the upper age limit is required, and they are open to that, and they in fact welcome it. So with that, I would like to conclude saying that increasing the age for donation will definitely increase the donor pool. Safety of the data is definitely there, and the physiological rationale for which we think that these people should be deferred is actually not substantiated by the clinical outcomes of the donation or anything. Considering India's blood shortage and the upcoming demographic trend, I would stress and tell that yes, it's definitely viable to look for increasing the age of donation in the in our country. So with that, this is my last slide. With the fever growing everywhere, we all know these people, especially Cristiano Ronaldo, my favorite, who is 41 plus and still playing. Gone are the days where people used to tell people who play football usually retire by 20 or 28 or 30 years. and we see a lot of players still playing, Messi and all. And good thing is these people continue to donate blood, and they have been donors and proved that uh, age is just a number and should not be affecting other things. Thank you.
Thank you,
Thank you.
Dr.
Yes, Ronit, continue.
Thank you. Thank you, sir. Thank you, Dr. Abhishek. And I think you very rightly said that these days the life expectancy is increasing. And because of this, we are going to get more donors in the elderly age. And moreover, such donors, they are motivated and they can prove to be more safe donors because they'll be ultimately turning out to be regular donors. But I think at the same time, the health of the donor will also be important. And I think Dr. Deepti, the next speaker, will be speaking against the notion, and I'll request Dr. Chaudhary to introduce her.
Yes, sir. Thank you. Thank you, Dr. Ronit. It's my pleasure to introduce one of the best students, Dr. Deepti. I will call her my student even today. So Dr. Deepti, she has done MD at our institute under my guidance and the PDCC as well. She has more than 17 years of experience. She is a joint secretary of ISTM, convener of therapeutic apheresis and cellular therapy, and she has received many awards of like Young Investigator Award, Usha Gupta Award, Young Scientist Award, Harold Bunsen Fellowship. And here I would like to highlight that for the first time in India, when she did her thesis, we found out the prevalence of heparin-induced thrombocytopenia in patients undergoing cardiac surgery. So this was her work, and this was for the first time we established the incidence, and Deepti did a lot of work, a lot of efforts to get sample and do all that studies. So now I request Dr. Deepti to present her point of view with regard to whether should we increase the upper age limit of the blood donors. Thank you.
Thank you, sir. It's my real pleasure to be introduced by my mentor, Chaudhary sir. Good evening, everyone. Chairpersons, colleagues, participants, ISTM, R.I. Sharma sir and SIG team. Thank you for the invite. Is the slides visible?
Yeah.
So today I will be speaking against the motion that India should increase the upper age limit for blood donation. Let me clarify that this debate is not about questioning the generosity, commitment, and the social responsibility of our senior citizens. The contribution to society is invaluable. Also, this debate is not about that whether some elderly individuals can donate safely. Certainly many can. And the real issue is that whether India should adopt a national policy that can expand the eligibility of an entire age group despite of increasing operational challenges and the health vulnerabilities. Blood donation, we all know, is a medical procedure which is performed on healthy volunteers, and that makes it our ethical responsibility to keep it safe, and it's our first responsibility. And that gives the question, which is a very simple question: should public policy expand donor eligibility? If we have the safer alternatives in place, do we really need to expand the age? My answer is no. And my flow of my arguments will be, first, why increasing the age limit does not solve the real cause of blood shortage. Second, why donor safety becomes increasingly important with age, we should not forget. Third, India's specific realities that may make this implementation difficult. And finally, I'll have some practical alternatives and rebuttal to Dr. Abhishek. Coming to the first argument, that yes, increasing age limit does not address the root cause of blood shortage. India needs more donors, but whether it is really the challenging situation is the participation of people or the shortage of people. India has more than 1.5 billion people. And most important is we have the largest youth population. Hundreds of million donors are eligible, and still we are talking about blood shortage, and we are trying to solve the symptoms rather than the cause. The problem is participation and not the population. We have a huge eligible population, and we have to think what we can do to increase the eligibility or make those people donate blood. Definitely we need more donors, but the challenge is low voluntary participation, poor donor retention, inadequate awareness among people, and suboptimal donor recruitment strategies. So the solution is not to be dependent on elderly donors, and it is time that we have to think rather than thinking how to increase the eligible donors, how we can improve the systems to have the current eligible donors donate blood. The second argument, the blood donation policies must prioritize donor safety, because that is the foremost thing for us. Blood donation is unique because healthy individuals are voluntarily donating. As the age increases, we cannot ignore that the physiological reserve decreases, the immunity, the immunoglobulins decreases, the recovery becomes slower. We all understand that chronic illnesses become more common, and so the multiple medicines and polypharmacy in these donors. Adverse reactions may not be more, it may be similar, but it may have serious consequences if we have. The young donors, if they fall, they may not have a serious consequence, but a simple syncopal episode may result in fracture, head injury, hospitalization, or a prolonged recovery. To add on that, a syncope or a fall in elderly donors, it is very important because more than 65 years, 1 in 3 adults falls every year. And this is not me, it is WHO saying that the risk of fall increases with age. And that is one of the cause of fractures, hospitalizations, mortality in elderly people. So the question is not whether the older donors faint more often, it is whether the consequence of fall will become more serious as we age. That is definitely there. And by blood donation, we should not increase the risk for the donors. And the third point is practicality. By increasing the elderly age donors to donate, we will increase the operational burden. We will require to have more stringent medical screening. I think current donor screening is primarily for the standard donor population. Our questionnaires may not be sufficient to identify the medical risk. We will require more physician review, more medication reassessment, cardiovascular risk evaluation, functional status assessment, which may not be very stringent in all blood banks. We are not talking about few blood centers. We are talking about national policy. And these bring the challenges of longer processing time, higher deferral rates, and more manpower requirement, because we cannot skip these donor screening lightly. We have to evaluate them properly. And hence, public health policies, we have to be practical. We cannot go by emotions, and we cannot be aspirational that we need elderly donors. Moving on to the second arguments, which is India specific. We cannot adopt developed country policies. We have to understand what we have different in India. One of the most important things that India has a high burden of chronic disease. Many elderly Indians are living with hypertension, diabetes, cardiovascular disease, anemia, many times multiple diseases. And more important is many people don't know, they are not aware. So just a healthy looking person may not have a fit person, they may not give a history. On this, we are having surveys every 5 years by longitudinal aging survey in India, where it says almost more than 50% people, elderly people, have one or more chronic diseases. Almost 1/3 people have hypertension. 14 to 15% people have diabetes and multiple other chronic diseases which cannot be ignored. On other side, this longitudinal studies tells that the population have anemia, which in females is 40% and men has 34 up to 34%. These older adults frequently experience iron deficiency, nutritional deficiency, and by blood donation, we are depleting the iron reserves, and they may become more vulnerable to anemia And definitely we have to understand that we should not give additional physiological stress. Third important point is, which is more important when we are trying to adopt the extending the age limits, where the developed countries, they are operating and they are allowing higher age limit. They operated within a strong healthcare system. They have advanced donor screening, strong healthcare infrastructure, better emergency support, and better screenings. While in India, we have rural healthcare shortage, there is variable access to follow-up care. The preventive screening is not happening properly. Health checks are not everyone is going for annual health check, and there is a very limited geriatric care infrastructure. Definitely, policies should match India's reality. We cannot imitate international policies before strengthening the healthcare structure in country. When we talk about blood donors, are we ready to effectively, can we monitor in blood centers if the donors are beyond 65? We need to have a good electronic health record system. We need to have a good donor surveillance system, geriatric support, hemovigilance systems. These all are there in developed country to follow these donors, to follow their database, their health records. But in India, we lack it. And before going for this extension, we would need substantial strengthening of donor surveillance before we can implement this age extension. Also, in our country, awareness and late diagnosis is very common. People don't know, and the recent biomarker study has shown that actual people don't know that they are diabetic, they are not aware of their conditions. And the study says up 16.2% of 60 plus aged group people didn't know that they had diabetes. When they were checked, HbA1c was higher. So here it is important that when the donors are coming, where we are most commonly based on history, we may miss these people and we may somewhere give them harm rather than collecting the blood. Again, digital and healthcare literacy, where in developed countries, people are aware about their medical risk, what medicines they are taking. They are they are aware for their preventive healthcare, the guidelines, they are aware who should donate and not. But in India, even in the study, it is found that 86% people lack literacy. They are not aware, they are not following their medical health check, and they do not understand the health risk. All this is important because people awareness, blood donation cannot be done by emotions, by pressurizing that I'm okay, I'm healthy, we can donate. We need to have awareness about our health as well as the health risk. Post-COVID, the situations have changed. There is an early onset of cardiovascular disease, the increasing burden of diabetes, hypertension. It is not a disease of 60s or 70s. Now we are seeing it in 30s, 40s also. There is a high prevalence of cardiovascular complications, even in young and middle-aged. When the chronic diseases are affecting India in 40s and 50s, I think expanding the blood donor age limit should be preceded by better health screening and donor surveillance system. I think upper age limit, if we are increasing it, is neither medically wise nor socially responsible. Again, as Dr. Abhishek told, the elderly population is increasing. It is currently 10 to 11% more than 60 age. It might go up to 25% in next 10, 15 years. We are expected, definitely it is going to increase, but I think along with that, it becomes more important that responsibility to take care of their health. And again, collecting blood, it is our responsibility to keep it safe, and donor safety should be our prime. We cannot take it without understanding the donor safety of elderly population. We have alternatives, and the alternatives are many. Without doing any further eligibility increase of age, just by increasing the youth participation, just by focusing on colleges, universities, first-time donors, as maximum donors are from 18 to 35. If we just focus on that and just few percent increase of those eligible population, we can increase. By improving repeat donor retention, having a database, reminder systems, and recognition programs, we can improve. Improving the blood system efficiency by managing the blood, by interactions of the blood centers, we can improve the logistics. By expanding the voluntary donation program, we can improve the blood collection. We need not to go for the eligibility change. So stronger systems definitely we can have by increasing the awareness and increasing this And these are the alternatives to increasing age limit. There are many points we can rebut, but the common points I will be finishing here before closing my presentation. So my first rebuttal to healthy elderly people can safely donate. Yes, some people can donate, but the policy is not about few people. It is not exceptional. We have to protect the population. And when we talk about policy change, we have to think at the larger scale. It cannot be built around the exceptions. And we have to see that whether our infrastructure, screening systems, and donor surveillance is at the same pace where the developed countries are. Second rebuttal, that other countries are allowed beyond 65 and 70. Context matters. Just age is just a number. We cannot go by age. We have to see what other countries have and we are not having. We don't have a screening systems, better healthcare, preventive monitoring, and restrictions. Even there, many donors, they are asked to go for health assessment before coming. Are we ready for that? I don't think we will be able to follow that to send them and get a clearance from the physician before coming for donation. So chronological age actually does not tell the full story, and India is definitely different from developing countries at this point. Third rebuttal, India needs more blood, yes, but the problem is participation, not population. And the fourth important point, that people should have freedom to donate. Yes, freedom is there, but it must coexist with safety, and we need public health policies to safeguard the donors. Again, humanity should not be measured by donating blood. Senior citizens above 65, they can contribute by many other ways, by mentoring, volunteering, caregiving, and community service, by motivating many other groups for further donating blood. And we should not create pressure on them to donate blood beyond an age. I think most of the time when the patient comes, their parents will be forced here to donate. Just if we extend the age limits, that will be the one point which we should be worrying about, that age is one caution which we are actually using to safeguard them as of now. So compassion must be balanced with medical responsibility. With this, I'll close that increasing the upper age limit may appear compassionate, but we have to prioritize safety, practicality, sustainability, and evidence. And India does not need to expose elderly citizens to additional risk when we have the safer solutions. And future of blood donation lies not in expanding vulnerable population, but in strengthening safe and voluntary blood donation. And I strongly oppose this motion. Thank you.
Thank you, Dr. Dipti, for putting your point forcefully. And here, before I go to Abhishek for his rebuttal, I would like to give 1 point in favor and 1 in against. One, I agree with you that there are comorbidities in elderly population. So the question will be, if you allow the donors above 65, how many units you will get? What will be the yield of donation in a year? It will be very negligible. For example, I analyzed the data of donor deferral at our institute in SGPGI last year only. And the donors who were in the age group of 50 to 60, the donor deferral rate was 30.7%, as opposed to donor who were just 20 to 30, that it was just 10% in that age group. So what I mean to say is that even if you allow, there will be too much of deferral. So you will be wasting your time in donor screening. You may have to do a lot of testing, laboratory testing also. For example, if you find that there is a history of diabetes, then you might have to do blood sugar level or HbA1c of that donor. And in opposed to that, what will be the yield? What increment you will get in donation? That will be very negligible in number. So that is my point in favor, against that motion. But 1 point in favor is that this policy is discriminatory. Why somebody, if he is willing to donate, why we should deny him that chance? For example, in India, we are not allowing donation from transgenders. So they are filing cases after cases in Supreme Court that this policy is discriminatory. So the selection should not be gender based. It should be neutral, gender neutral selection. So whosoever is medically fit, he is allowed to donate. So that is the policy adopted in the Western countries. But obviously we cannot do it in India. So this policy of not allowing the donor above 65 is discriminatory. Where if somebody is willing, he's healthy and willing to donate, he should be allowed. So one point is in favor, one is against. So before we go into the further discussion, I'll request Dr. Abhishek to give his rebuttal.
Yes, sir. Thanks for the opportunity. So I will directly rebut 3 points of the person who spoke against the motion. One is the speaker was concerned about the falls, especially in the elderly. So now I want to tell that uh, it is sad that in a country like India, most of the time, what do we actually give the donors? For example, if a donor wants to donate blood, he has to come by himself to the hospital. He has to donate time, travel, and he has to go back. So we don't have a system, social support that we give to any of the donor. Forget it for the elderly alone. So this responsibility of blood bank beyond just the donation, not even providing a parking space, and these are small issues, but yes, so that has to be improvised for every one of them. And when that is improvised, it will take care of the elderly donors as well, where there is a system where they are guided and brought to the donation center and drop them back and things like that, and this may go a long way in expediting and avoiding the falls. The second one about the expertise of people, um, they said that the policies are made in such a way that all the hospitals or I mean the blood centers should should follow it. So since there is no enough expertise to individually examine a donor and decide whether he is fit to donate or not, but that is not a fair argument in the sense we all know that every hospital is different. Every care is not present in every hospital. There are many hospitals who treat pregnancies and deliveries without a blood bank itself. So we know that there is a difference. But the expertise like transfusion medicine, which was not even heard of 10 years before, has become widespread now. There are a lot of hospitals who have this expertise. Why should we stop them from going for these policies? We cannot do it an equal, but yes, but people who have it can go for that. For example, transplant. How many hospitals has a transplant? That doesn't mean we should stop transplant as a whole. So whoever has that opportunity and expertise, let them go for it. The third one about the investing in a lot of diagnosis and investigations in these kind of people, I would feel it is good in the sense many of the hospitals or blood banks allow this investigation as a what you say as a free this one master health checkup or something for the donor. So in that sense, continuation of this would actually help this, because we all know that healthcare seeking itself is so bad in our country. Many of the people do not go to the hospitals in spite of having an advanced disease or so. And we all know that lots of papers are coming where blood bank has been able to pick the people with hypertension or diabetes early and refer them to the actual care and help them in getting the care. In that case, I don't. So I feel that it is good that these people come, even if they are aged, they come, they get investigations done, and they get a care rather than go unnoticed. Thank you, sir.
Yeah, thank you, Abhishek, for a nice effort at defending indefensible. So, so now I open the debate for discussion. Comments from the members invited.
Sir, there are no questions in the Q&A, neither in the chat box. So if you allow, we would proceed with the next session.
Yeah.
The next
Thank you.
session.
Thank
Yes.
you, Dr.
Thank
Suchet.
you.
Thank
Yeah,
you.
thank you
Thank
very
you
much.
to SIG Group and ISTM for giving us the opportunity. Thank you.
Thank you
Thank
so
you.
much, ma'am. Thank you. Grateful for being with us. Now we go to our third session, and that also deals with deferral from bite to ban, how deferrals are shrinking our donor pool. And for this, I would like to invite Dr. Asim Kumar Tiwari as the chairperson, along with two of our SIG members, Dr. Satya Marora and Dr. Amita. Dr. Asim actually needs no introduction, and he's a stalwart in transfusion medicine and working at the Medanta Medicity. He's at Gurgaon and he has a lot of accolades. He's a recipient of Dr. H.D. Shorey Award, Dr. J.R. Jolly Award, and Mother Teresa Award. Asim, can I hand over the reins to you?
Yeah, thank you, Dr. Suchet.
Thank you.
We'll straight away go to the speaker. Can I have the speaker's introduction slide, please?
Rahul, please display my Dr. Rasika's CV.
Thank you. Dr. Rasika works as Director, Department of Transfusion Medicine at BLK Super Specialty Hospital. She has a keen interest in immunohematology and stem cell transplantation. She specializes in hematopoietic progenitor cell collection and therapeutic apheresis. She is a faculty for DNB immunohematology and transfusion medicine at BLK Max. Is a certified NABL assessor. She is a committee member for Foundation for Quality India Delhi chapter. She has authored a chapter on quality assurance in blood banking in WHO series. She has several other publications and she is a recipient of Dr. Usha Gupta Award in Transcon 2024. And I have known her, as a collaborator and, for a person who gives a very thought-provoking talks. So thank you very much, Dr. Rasika, for receiving the invitation. And are you there, Dr. Rasika?
Yes, Dr. Singh.
Yeah, please. So I hand over the stage to you. Thank you.
Thank you so much, Dr. Singh, for the kind introduction. And at the onset, I would like to thank Dr. Chaudhary and Dr. Sharma and Dr. Suchet for giving me this opportunity to share our experience. I'll just share my slides. So, are my slides visible?
Yes, ma'am.
Yes, but you can.
Yeah. So, my talk for today is pause to pause. So, this reflects on how a simple animal bite can interrupt a donor's journey. And while donor deferrals are essential, but every deferral tells a story. So, are we listening or are we just losing out on our valuable donors? Today, I'll share our experience and explore what is the impact of these temporary pauses on our already fragile donor pool. So let's just start with begin with why these donor deferral policies exist. We all know them, just revisiting them. Primarily, it is to prevent transfusion-transmitted infections by excluding individuals who may be infected or have been exposed or to infectious agents during the incubation period or window period. The second is to protect the donor health by preventing donation during periods of physiological stress and medical vulnerability. Thirdly, to maintain blood quality products, ensure collection from healthy individuals capable of providing safe and efficacious blood components. But a chunk of deferrals is based on precautionary principles, even when the risks are theoretical or incompletely understood or not well categorized. These deferrals are implemented to maximize recipient safety, for example, recent vaccination and the emerging infections. So what is the impact on these donor deferrals on our blood donation and the blood supply? So whenever we have a deferral added to the list of donor deferral criteria, we reduce the donor blood availability. We have smaller eligible donor pools, reduce blood collections. Then there's an attrition of the donors because deferred donors may not return and loss of donor motivation. Reduced repeat donation because disruption of the regular donation behavior of a regular donor and reduced long-term donor engagement may eventually occur. Again, it actually impacts our donor, the inventory, and inventory vulnerability increases, especially in times of increased impact like dengue or trauma situations or emergency situations. It would eventually lead to increased operational costs because we'll need additional donor recruitment campaigns, increased counseling and follow-up engagement. And finally, culminate into an impact on the patient care, challenges in meeting transfusion demands. Already, we have a shortage of supply and potential compromise in the
services and responsiveness. So coming on to the background, how did this start? So this is a report published by the Ministry of Animal Husbandry, Dairy and Fisheries, and a report where it's showing the number of dog bite cases reported statewise from 2022 to 2025. And Delhi has shown an exponential increase in the bite cases that are being reported. Rising animal bite burden in Delhi is something which is making headlines every now and then. But when you look at Delhi is still better off. You have many states which are reporting even much, much higher bite cases across. And what is the relevance of this to our blood transfusion services? It is relevant to us because whenever a donor or an individual has been, received an animal bite and has undergone a vaccination for the anti-rabies, we defer a donor for a period of a good 1 year. This is actually based on the concerns regarding prolonged incubation, delayed symptom onset, and a very high fatality rate because of this disease. And we do not have screening tests, and even if we have them, they may not be economically viable, and a theoretical transfusion transmission risk. So now within animal bite cases rising, we actually, because we are a part of the community and whatever happens in the community reflects onto our transfusion services, the rising animal bite cases may increase the temporary deferral of the donors which come to our blood centers for donation. And this impact eventually would lead to donor availability, reduction in the donor availability, and even the impact on retentions is unclear. So why did we actually go into this study? So it is something that, we were just sitting down and analyzing our data for donor deferral, and we noticed that over the last few years, we were actually seeing a rise in the number of donor deferrals because of animal bite and anti-rabies vaccination. So we decided, we went through the literature, started looking, and there was very little literature available on this, which was talking about it. So we decided to actually explore our own data. And with the objectives to see these rising bite cases in the population or the community was whether it was impacting our donor deferrals. Also looking at what was the reduction in the eligible pool of donors that we were having, and looking at whether this was actually causing an attrition in our donor population and loss of repeat donors. Because there's limited data, we went back and did a 4-year analysis from January 2021 to April 2025. And we started evaluating the trends in the donor deferral patterns and implication on the supply management. So in this period, on this 4-year period, we had almost 70,000 donors who were registered at our center, and 7,094 were deferred for various reasons, out of which 528, that is 7.7% deferrals, were due to anti-rabies vaccine following animal bite. And interestingly, they actually comprised the young male repeat donor population, around 62% of them, and the mean age was 35.5 years. And of these, 80.7% were the office goers, the deferred donors office goers who were moving around, and that is why probably exposed to these animals and getting these bite cases. And they're the economically productive and the socially responsive donor population who, because of their tendency to be moving around, are the ones who would hit a blood center for donations when you called for them. And when we looked at the kind of donors when they were coming to us, we looked at how fast after an animal bite did they actually report to us for blood donation. And almost 98% of them came back after completing a complete course of post-exposure prophylaxis. That shows that, they were like people who were medically compliant and the ones who had a very good impact, understanding of the health implications. So they are the donors who probably we would say would be ones who are, when we talk to them, would be able to understand what we are telling them. So then we started looking at a trend analysis, and we saw a rising trend in the donors deferred due to anti-rabies vaccination and following an animal bite year on year. And we also wanted to see whether it was something which was reflective of what is happening in the society. So we actually looked at, we went back to our emergency and went back to our procedure room to look at what are the post-exposure prophylaxis vaccine that has been received in the hospital for people who just come to the hospital after an animal bite. And our anti-rabies vaccine-related deferral following an animal bite rose from 3.8% in 2021 to 11% in 2025, which is a almost 190% increase in donor deferral. And a similar trend was seen in the animal bite-related post-exposure prophylaxis, which increased from 14% to 21.6%, a 64% increase. And what was shocking, that out of all the donors that we had deferred, at least though only 7 donors, that is 1.32%, returned after completing the mandatory donor deferral period. They would possibly, we can argue, that could have gone elsewhere to donate because it is a retrospective study. We could not actually go back to them and ask. But the assumption is because, you have people moving around in the same area as us. If they would have come back. But yes, only 1.32% came back to us for donation and after completion of their deferral period. So let's talk a little about blood rabies and blood donation. So rabies basically is a primarily intraneuronal virus and unlikely to be transmitted through blood. Rabies virus rarely circulates in blood, and blood-borne transmission is considered biologically unlikely. No confirmed cases of transfusion-transmitted rabies I have come across went through literature. Transmission of rabies through organ transplant and tissue transplant is well reported. There are cases that have been reported. Yet, a lot of international organizations still, because of the high risk of fatality, resort to this 12-month deferral period across the globe. So this is not something which is unique to our country. It is actually a worldwide deferral pattern that is being followed. But the current donor deferral, base is precautionary safety approach. We do not know whether, this deferral and this rising deferral that we have is really something which we are preventing a kind of infection that could possibly be transmitted through blood transfusion. So the story begins with a bite. A dog bite lasts a few seconds. A vaccine course 28 days. Deferral may last a year, but the impact on donor motivation can last much longer. A donor comes, gets fully vaccinated to be told that, he's rejected and is asked to go back. He's disappointed, confused, and frustrated. A motivated donor is now in doubt, doesn't know whether he should donate, when to come. A blood donation, which he thought was a simple process, now appears worthless to him. So the impact is very, deep, has a very deep impact, and not something that is just a pure, simple deferral. So are we listening? So what do donors often hear? You cannot donate for a year because you've received anti-rabies vaccination and you have an animal bite. But does the donor really want to listen to that? The donor actually wants to know, why am I being deferred when I have received a proper prophylaxis? Is this prophylaxis not good enough? Is it not safe enough for me? If it's not safe enough for a donation, that means even I'm not well protected. When can I return? Will you remind me to come back? Am I still being valued? So we need a paradigm shift from deferral to engagement. Every deferred donor should leave with a clear explanation, written information, next eligible date, appreciation, and a follow-up plan. A deferred donor should never become a forgotten donor. So that is something that should come here. Now coming to points to ponder and something that we can discuss and debate. We need a policy, review of our policy in India. The policy currently is a 1-year blanket deferral. But when we look at the WHO exposure categories for animal bites, they're categorized into 1, 2, and 3 categories. Different vaccine type and risk-based stratification, because we have the stray dog bites and the pet dog bites also coming into the same bucket, same basket they fall into it. If you have a scratch or you have a bite, anything that is there, we still put it into the same deferral criteria. Incorporation of the donor deferrals into the National Donor Hemovigilance Program to monitor trends and their impact on donor availability, and to review what these deferrals are actually impacting our blood donor pool and eventually the blood availability. Strengthen animal bite surveillance. Again, this is something which needs to be done. Stray dog population control, animal vaccination, and public health awareness initiatives. Implementation of digital pre-donation screening and triage to identify temporary deferred donors before they eventually present to the blood center and then get rejected. So this is something that we need to discuss, talk, and maybe, ponder upon. So thank you for your attention and looking forward to a discussion. So I would call ourselves Dr. Deferrals rather than people who are accepting, and we have ever increasing lists of deferral criteria which are there, which we need to knock off some and keep only the ones which we think are actually relevant. Thank you.
Thank you, Dr. Asika. That was an eye-opener that so many donors can be deferred because of animal bite and the vaccination. So I would request my co-chair, Dr. Satyam, Dr. Amita, would you want to add something?
No, sir, thank you. And ma'am, this was actually a very interesting talk considering Delhi NCR dog bite issues are continuously in news. It has even reached to Supreme Court. A lot of matters have been escalated to a very large extent, and how sitting in blood bank, all these uh, social issues and which are happening in society around us can really impact. And I must congratulate ma'am for bringing out this data and doing this publication. And just one question to ma'am, that from which AI platform did you made these cartoons? They were very nice and they really made the point very clear and just made the whole presentation interesting.
So that was Canva, something
Okay.
which is child's play, but yes, I've just started exploring it and trying my hand on it.
No, definitely, ma'am. It really passed on the message in a very casual and a very easily understandable manner. Thank you, ma'am. Dr. Amita, do you want to add?
Yeah, I do agree. Thank you, madam, for bringing out such a very valid point. I think in Kerala also we have lots of cases of dog bites coming and lots of donors are getting deferral. And as you rightly said, once the donor is lost, like he gets forgotten and he doesn't come back. We have had several of our regular donors which we have lost because 1 year they cannot come back for donation and then they go about their busy life. So we are losing our donor pool. Our donor pool is ever shrinking. So such things, I think it needs debate, and whether we can get back these donors, that needs to be like policies can be framed, whether we require 1 year deferral for such cases. Thank you, madam, for bringing out this very important point. And it was a very wonderful presentation. Thank you, ma'am.
Thank you, Dr. Amita. Thank you, Satyam. I don't see any questions in the chat box. Satyam, am I missing something?
No, sir.
We have no questions in the Q&A.
There is a comment that vaccination deferral is a big problem. Of course, all of us understand that there has to be a balance between accepting a donor and deferring a donor. We have to strike a really good balance. But I mean, the law of land as of now is 1 year only till we possibly have a policy of looking at it again. And as Dr. Rasika said, maybe differentiating between a pet dog bite and a stray dog bite, or maybe the degree of bite or something, maybe more studies would be required before we can change the period. But thank you very much, Dr. Rasika. That was very interesting and thought-provoking. Any other panelists would want to comment on it, please?
There is a hand raise from some Dr. Raman, I think, if they want to. Do you want
please.
to? Yeah. Can we give him the permission? I think he's seeking permission.
Team, please allow.
Can he put his question
Yes, sir,
if
yes.
he's not able to? He can put his question in the Q&A box.
Yeah.
Yeah.
That was hand is off eventful webinar host only. Okay. Thank you so much, Dr. Rasika. It was a very lucid talk and very well planned and backed with data from the dog bite data from the Government of India, and excellent presentation. We had actually asked Dr. Rahul Katharia, who is a member of SIG, for the vote of thanks. Neither is Dr. Ashok Yadav here, sir is busy with an inspection. So it's been a long day, and Asim, Dr. Sharma, Rasika ma'am, Satyam, and Abhishek, we are all on board. Let's click our video on and take a last snap. And then thank you everyone for joining. Team TMAC, please take a photograph. Abhishek, थोड़ा सा लाइट मारो उधर, लाइट ऑन करो कोई.
Okay,
Yes,
sir, we
Pinky is
take it.
there. Amita, Dr. Ravneet is also on board. Madam, can you please switch on for a second the video?
Dr. Akanksha.
Dr. Akanksha. Chalo, whosoever is possible, we'll take a small snap and then we'll call it a day. Thank you, Amita. Tarun? सत्यम आप ही ले लो एक फोटो इसका स्नैपशॉट.
Done, sir. I have taken.
Thank you
Yes,
everyone.
sir. Photo ले लिया.
ले लिया. Thank you. Thank you, sir. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you, Dr. Suchet. Thank you.
Thank you, buddy.
Thank you.
Thank you all. Thank you.
Thank you, sir. Thank you.